Okay, fine. So, say Trendelenburg sign. So Trendelenburg has significance because uh, he's a German surgeon who found out a lot of different things. So back in 1897 is when Trendelenburg described the Trendelenburg sign for pathological hip abduction issues. So that's Frederick Trendelenburg. Back in the 1890s, I think around 1897 is when he described this particular test for identifying hip abductor weakness. So the hip abductors in question here are the gluteus medius and the gluteus minimus. Now, what are the prerequisites for this test? The patient should be able to stand on the affected side for more than 30 seconds. Okay, more than 30 seconds. So this is a prerequisite. The patient is not able to do that. The patient is exempted from doing this particular test. Okay, the patient should be able to understand your commands, should be having an intact coordination. So people having cerebellar issues will not be able to do a Trendelenburg test. Apart from that, fixed coronal plane deformities are also exempted because there has to be a free abduction movement in order to have a positive test. So the moment you realize that the patient is having either a fixed abduction or an adduction deformity, and the pelvis is not square and KSIs are not at the same level, that means most probably you will not be doing the Trendelenburg test and you have saved yourself those extra 1 or 2 minutes. So how do you do it? You position yourself behind the patient. The patient has to be comfortable. So talk to the patient. The patient will have to undress adequately. The underwears have to be pulled up so that both the gluteal folds as well as the iliac crest are seen from the back. Now you have to stand, the patient has to be standing and the examiner has to stand behind the patient at the level of the gluteal folds, with the eyes at the level of the gluteal folds. Now the patient is asked to lift each foot off the ground and hold for at least 30 seconds. Now when you check for the left hip abductors when they are being tested, the right foot is lifted. The right foot is lifted for the left hip testing and vice versa. That is, the left foot is lifted when you want to check the right hip. Why is that so? It's because when the patient lifts the right foot off the when the patient lifts the right foot upwards, okay, when the right foot is being pulled upwards, the pelvis has to stabilize. So what is natural history when you lift it up? Because of gravity, it is supposed to fall down. The pelvis is supposed to sink downwards. But that does not happen because the abductors on the left side, they start acting and they make sure that this angle is maintained. And when this angle is maintained, this pelvis remains square. It does not fall down. And that is why when a right leg is lifted upwards, it is the left hip which is being tested. And when the left leg is being lifted upwards, it's the right hip which is being tested. Okay. And once the foot is lifted, we observe for the level of the gluteal folds and the iliac crest. So you have the iliac crest coming from top and the gluteal folds below. Now, if the right hip is lifted up, right foot is upwards. If the right foot is upwards, the left hip is being tested. Is being tested. Which side will sink down? The side to sink down will be the side the foot is lifted up. So that is the normal side. Okay, so we have a small mnemonic for this. That is the sound side sinks. Why is this? This is because of gravity, the sound side will sink. Okay, because of gravity, the sound side will sink. Because the counter force for the gravity is the hip abductors on the opposite side. the hip abductor on the opposite side is damaged. This is not working, and that is why the sound side will sink. That's the normal side will sink. So either the gluteal folds will sink or the iliac crest will sink. Either one of these two can be observed. Okay, so it is a positive test if there is dropping of the pelvis on the unsupported side. That is the sound side sinks. Why does this happen again? This is because of the abductor muscles failing to stabilize the hip towards the weight-bearing femur. So if you see the illustration down here, when the right leg is lifted upwards, the left abductors come into action and they make sure that the pelvis is stable. Okay. Now what happens in an abnormal patient is the abductors are not working, so there is no counter force for the gravity, no counter force. So when the right foot is lifted upwards, the pelvis starts to drop down. The pelvis starts to drop downwards and the pelvis sinks. The gluteal folds also sink. So the normal side, the gluteal folds will be same, but on the abnormal patient, the gluteal fold on the normal side will fall down. So what are the positive causes for positive Trendelenburg test? It can either be skeletal or neuromuscular. The skeletal problems are developmental dysplasia of hip, coxa vara, a short hip, a short coxa breva, SCFE, sequelae of Perthes disease, chronic subluxation or dislocation of the hip, acute dislocations of the hip, fracture neck of femur, a greater trochanteric fracture, a fractured neck of femur non-union, a greater trochanteric avulsion injury, anything which involves the either the greater trochanter, the absent femoral neck, or absent femoral head. Okay, so these are all the skeletal things. What are the extraskeletal things? Superior gluteal nerve injury. Why this particular nerve and not any other nerve? Because superior gluteal nerve supplies both the hip abductors, that is the gluteus medius and the gluteus minimus. And we know that the superior gluteal nerve has a supply from L4, L5 and S1 with L5 taking predominance. And that is why a L5 radiculopathy is also another cause for a positive Trendelenburg test. Apart from this, a gluteus medius or minimus tear, tendinitis, weakness due to poliomyelitis, muscular dystrophy, or any other neuromuscular disorder can also lead to a positive Trendelenburg test. And lastly, it is of very much importance to know that if there is pain, then that also will lead to a positive Trendelenburg test, because the patient is unable to abduct the hip because of the gluteal weakness, and this is very commonly seen in osteoarthritis of the hip. Apart from these positive causes, we have a lot of false positive causes. Okay, so the false positive causes are obesity, a fixed adduction deformity, medialization of the lower limb axis such as coxa vara, genu varum, a non-intact quadratus lumborum. That means the pelvis from the upper aspect. Now we already talked about below the pelvis. Now we're talking about the spino-pelvic relation. Among the spino-pelvic relation, if the quadratus lumborum is not affected, then the pull of the pelvis upwards does not happen. Okay, so that is also a cause for false positive Trendelenburg test. Pain, poor balance, lack of cooperation, a costopelvic impingement, scoliosis, or a pelvic drop can occur even in a normal healthy individual or a weak individual where the abductor muscles are not functioning adequately. Then we have false negatives, where the suprapelvic muscles are very strong. That's the quadratus lumborum is very strong and it's able to pull it upwards. Okay, so that's a false negative. Use of psoas or rectus femoris muscles to pull the hip upwards. That's another cause. A wide lateral translocation of the trunk to allow balance over the hip as a fulcrum. So you're not able to find out that the pelvis is that the patient is swaying to the abnormal side. So that's a wide lateral translocation of the trunk. Okay. And in patients with very early stages of osteonecrosis, despite having the abductor mechanism intact, the Trendelenburg test can also can be a negative, okay, because the gait often remains masked. Now coming to the anatomy, we talked about the two hip abductors, that is the gluteus medius and the minimus. So on the right side, we see that's the gluteus medius, and the ghosted thing over here is the minimus. So that is the minimus, and the blue thing is the medius. Okay, or we can show this as the minimus. Okay, so the minimus is more anterior, the medius is more posterior, both in origin and insertion. Okay, so
Thank you, sir. So thank you for the excellent talk as always. So if there is no any other doubt, I think with the permission we can call it the day, sir.
Sure thing.
Thank you, sir, and good evening, good night, bye.
Good night, bye.